Välkomna till Perspektiv Direkt. Idag ska vi titta på en paneldiskussion från San Antonio Breast Cancer Symposium. Den hölls i slutet av förra året i just San Antonio. Det är ett gäng läkare som pratar om hur det fungerar i praktiken för både patienter och personal vad gäller just Paxmans huvudområde, skalpkylning för att motverka håravfall. Den är på engelska, men det är värt det om man är intresserad av den här tekniken. Har ni ramlat in i den här videon utan att först kolla på introduktionsfilmen kan ni klicka er in på bolagsintroduktion direkt om Paxman, så får ni en 3 minuter om allt ni behöver veta om företaget. Nu rullar vi klippet från San Antonio.
Hello, I'm Hope Rugo from the University of California, San Francisco's Comprehensive Cancer Center, and we're here with eCancer at the 2018 San Antonio Breast Cancer Symposium to talk about an area very important to our patients with breast cancer, both in the early and late stage setting, scalp cooling to prevent chemotherapy-induced alopecia. Here with me today are my esteemed colleagues, Debut Tripathi from UT MD Anderson Cancer Center, and Professor Nadia Harbeck, who's from the University of Munich in Germany, and Dr. Stephen J. Isakoff, who's at Mass General Hospital Cancer Center. Thanks for being here.
Thank you.
Everybody here has experience with scalp cooling and the care of their patients who are being treated with chemotherapy. And one of the things that we wanted to do in this session is to talk a little bit about the issues that breast cancer patients face regarding treatment options and adverse effects and what kinds of things influence them, and then the progress we've made in trying to address particularly chemotherapy-induced alopecia. So we'll start and just get a feeling from everybody about their experiences in practice about what the most important issues that patients face. And mostly we're thinking about patients with early stage breast cancer, although certainly in my practice it's a big issue for patients with metastatic disease as well. Steve?
So in our practice, obviously hair loss is a critical issue for patients. I think there are a number of studies showing that a number of women, up to 8%, will actually decline chemotherapy because of the risk of alopecia. And so at our institution we started scalp cooling, initially patient-driven. About 4 years ago we had our first patient come to us and ask if they could do this, and we were very supportive of that. And one of the challenges has been obviously that when patients do this themselves, it was fairly labor intensive, and then about 8 months or so ago we obtained our machines and started a scalp cooling program, and the uptake has actually been quite good. We've had at our hospital now about almost 60 patients in the last 8 or 9 months elect to do this. And even in patients where it hasn't worked, or even patients who've declined the option to do it, they've expressed a real gratitude that this was even an option and that we're thinking about this because it's such an important issue to them.
One of the big issues I think that face women who are looking at a diagnosis of breast cancer in the early or late stage setting is a tremendous loss of control. And so maybe that's a big part, I think, of this, as well as just a sense of normalcy. Do you find also in Germany that patients are concerned about hair loss?
Yeah, I think they're afraid of chemotherapy, and hair loss is one of the biggest issues for them. So we started scalp cooling about a couple of years ago, and interestingly enough, the objections came also from the nurses, because we have a couple of older nurses in our ward who still remember the old days of scalp cooling with incredibly big machines that made a lot of noise and didn't really help patients much. So they were quite reluctant, and we started with the more modern systems, and actually we started to convince our nurses, and the patients really loved it. And my take-home message from my first experience over the first year is that it's critical that the nurses have a good attitude towards it, because they're the ones fitting the caps, helping the patients, talking to the patients. So if they're convinced that it's helpful, the patients have an easy time sort of getting used to the little bit more pre-cooling and post-cooling time. So it's critical that the whole team is behind it, but particularly the nurses.
It's really true. I think certainly at our center, having the nurses be on board was critical, because there were 2 reasons why they weren't on board. One, they were very suspicious that it wouldn't work or it would be bad, or people have terrible headache, whatever. And that just requires a little experience for convincing. But there's a second issue for our nurses, which was the concern about an additional amount of work per patient and how they would fit that timing in. We actually dealt with that by having medical assistants help out, as well as people who've graduated from college who are coming to work with us in research for a couple of years will take on that kind of support project along with their research.
So I think that's a very important point, and we started to have like one scalp cooling day. Now we have 5 scalp cooling days. And we have a smaller room with the machines, so the patients that don't get scalp cooling, like we also treat gynae patients, they don't get sort of also want to do this and ask a lot of questions. So we have this in a separate room. It works quite well, and we just you have to plan properly, and that's where the nurses come in as well.
Yabu?
It's very variable across patients, but most patients do want to preserve their self-image and be able to interact with people without maybe knowing that they're being treated for cancer. Cancer can be very isolating, so anything we can do to help patients maintain the normalcy of their life is critical. So we were really happy to be able to start offering this a little less than a year ago, and we went through a process to make sure that we worked out the logistics. Many of the things we've talked about here are very important for things to run smoothly. And it was really good that more safety data came out, more efficacy data came out from randomized studies that gave us a sense as to how effective it is, and if there's any safety or discomfort issues that we can know what they are and be able to communicate them to patients. So the field really has moved forward and enabled us and many other centers to do this. So I think it's really been a big step forward. We always want to do everything we can for our patients, and sometimes we get so caught up in the medical advances that we lose sight of some of these things that are very important to our patients and therefore important to us.
Yeah, it is fascinating. Certainly when I was a medical student a very long time ago, people would use these, ice, just put ice together and try and keep their hair, which didn't work very well. But it was a patient also who brought up the whole idea of scalp cooling and why it wasn't available in the United States except for on one-off situations, and started us on the road of trying to get FDA clearance of scalp cooling devices. And in that process, we've all learned that there are 2 major different kinds of scalp cooling devices: the manual kind, where the patient has to actually change the frozen cap every 30 minutes. And the downside is the more time intensive, which you've also had experience with, and needing a freezer or dry ice. And also the risk, although small, of thermal injury, because the cap has to be so much colder when it goes on the head, versus the now and continuously improving automated devices, which everybody has now at their institutions, of us, the group here, where you have an automated device that can actually be wheeled around, is small, can serve 1 or in some situations 2 patients, and has a cap which can be fitted to the head and has circulating coolant, so you can maintain the temperature, which avoids the risk of thermal injury, which is great. Although we still have to do the post-cooling time, so scalp cooling does involve more time and certainly the cold sensation for our patients. But I'm curious if you have had patients use scalp cooling in the metastatic setting at any of your sites.
So we definitely have. When we launched our program, we took the approach that we would not be restrictive. And so we actually allowed any chemotherapy regimen for breast cancer and allowed metastatic patients. So we've had patients do it with paclitaxel, with eribulin, and with some success. If the drug is working, obviously this is going to be more than just the typical 12 weeks that one might get in the adjuvant or neoadjuvant setting. But if it's working, I think the patients are also inspired to want to continue. So we have done that, and we've actually just expanded our program now to include gynecologic patients, many of whom have advanced disease and will be getting this with Taxol-based therapies.
Yeah, the approval now in the U.S. has been expanded to allow patients with solid tumors to use the device, which is great and I think helps our centers.
I mean, you mentioned it before, I think we should not think about scalp cooling just for the early breast cancer setting. We also want to start treating all gynae patients. So far we've done it in a trial, so we had to restrict it to breast cancer patients, but I think in particular in the first line setting, patients do not want the whole village or their whole suburb to know that the cancer is back. So I think, and we usually have a taxane-based regimen, the first line setting, and our best experiences are with the weekly paclitaxel regimens, be it with antibodies or just by itself, and that obviously we use a lot also in the first line setting. So I think scalp cooling is a great way forward, but we shouldn't restrict it to the early breast cancer setting.
We started with breast cancer and really emphasized more the taxane only, but we knew that we were going to expand it once we got more experience, and we just had to ramp up slowly. So we have in fact now expanded. We're starting to treat patients with gynecologic malignancies as well, and pretty soon I think we'll expand it more and more. It's just really more a matter of logistics, but we want to make it broadly available.
Yeah, we recently had a woman with bladder cancer use scalp cooling, but they have to, of course, go to the place where the machines are. But I've had one young woman recently who has, gone through multiple regimens of chemo and has never lost her hair in the metastatic setting. Incredibly important to her, for her kids and her family, and maintaining that at least little bit of control on quality of life. We certainly have had some challenges in scalp cooling in terms of not just the devices and et cetera, but also the chemotherapy regimens. And we were talking about that a little bit, about taxanes, et cetera. But some of our patients, although I have to say less now than before, receive anthracycline, taxane sequential regimens. I don't think many patients in the U.S. receive anthracycline alone regimens anymore. Some places in the world, clearly that's still the case. But we had two studies that led to FDA clearance of two different automated scalp cooling devices. One of the studies included anthracyclines as part of the chemotherapy regimen, and one didn't. And that study with anthracyclines was a truly randomized trial out of Baylor, Julie Nanja's trial. But the interesting thing about that, I thought, was that there was some disappointment in how well the cap worked for anthracycline-based regimens, but it was clearly dependent on experience at the site. And we've certainly had patients who kept their hair with anthracyclines. Do you have experience in that area?
Yeah, so most of my experience, because our program is about 8 months old with the device, with the manual use, we've actually had a fair amount of experience over the past few years with actually quite good success. With the devices now, I think, as you've well said, there's a learning curve, and our team is getting more used to that, making sure that the cap fits snugly and that the patient notices that they have even coolness on their scalp. I think will make a difference, but we have seen success with it. I always caution patients that success is lower with anthracyclines, but we're certainly happy to try. The other thing I would mention is in patients who still do lose their hair, patients will always ask, should I get a refund or should I keep going? And what I tell them is, well, if you lose your hair, you're going to have better contact with your scalp, and it probably will get it colder, and you may actually start to regrow hair before we're all done with your cycles. And we've seen that in the past, that by the time patients are finished with their taxane as the second treatment, they're already having hair regrowth. So it's a tricky question about whether to continue once someone's lost their hair. And I don't know if you were going to mention it, but there was a recent publication showing the use of scalp cooling to prevent the potential pervasive alopecia that one can see with docetaxel, which implies the same kind of finding, I think.
Yeah, it is interesting. We had one woman who chose not to use it, and then she lost her hair, and then she got really tired of it because she's on metastatic, immunotherapy, paclitaxel program, and so she started using it again. And the one caution, of course, is that you have to really protect the scalp, so it's not too cold right close to the scalp. But of course, now she has a full head of hair, and she's still getting chemotherapy. So I think we all feel like, there used to be this idea that maybe your hair would grow back more quickly if you use scalp cooling, which never made any sense to me. But what really is true is that it probably does. I mean, you fill in faster, you grow still at the end of your chemo. So I don't know if anybody else has, before we start talking about the papers, experience with anthracycline regimens.
Yeah, I think in the beginning, we wanted to try every regimen. Our best success rate obviously is with paclitaxel weekly, where we have like around 90% success rate. I think You can try anthracyclines, and there are some papers, our success rate is about 30%, but there's other papers showing about 50% success rate with anthracyclines. I think you shouldn't promise too much to the patient. You say, we can try it, like you said, but I cannot promise you. I wouldn't use it probably with dose-dense anthracyclines. I don't think that makes much sense with our experience, but with the 3-weekly regimens. And we also had good experience switching. They're doing the taxane first and then the anthracycline, and patients were able to keep their hair.
I think that's a really important point, because our patients generally receive the taxane first. We do a lot of neoadjuvant therapy when we're using an anthracycline. And what's fascinating, I think, is that it does appear that having experience as the patient, not just as the institution, makes a difference. So if they use the cap during the weekly paclitaxel, we only use dose-dense anthracyclines in general in the US, and it doesn't seem to make any difference whether it's dose-dense or not. And so we have had people keep, the definition of success being generally keeping about 50% of your hair, which I have to say you got to tell patients about, because that's not their idea of not losing any hair, but it does help a lot and really makes a difference. And in the trials that were done and the trials that have been reported, there is universal appreciation of use of the cap, or even being just offered the cap, as well as an improvement in some of the patient-reported outcome, assessment of self, et cetera. And are you using it also with anthracyclines?
We're just getting started, but we did decide to keep a very careful record, because we have a comparative effectiveness committee that looks at everything we do. And so we do want to be able to report what we're seeing, and also just present to our patients what we're seeing. So I feel a little more confident that we're going to see good results. I think we were also a little biased by the differential results that were being reported, but we're looking forward to adding that group of patients in.
I was excited to see a number of different abstracts being presented at this year's San Antonio meeting about scalp cooling. One area that, of course, has been concerned, and even after we presented the 2 trials, I heard from very big placed people that there was still concern about scalp metastases because of poor delivery of chemotherapy to the scalp. At this meeting, we reported a longer-term outcome now with 3 to 4 year data combined, showing no scalp metastases in the group of patients we treated with one automated scalp cooling device. And certainly, I think that's generally so far been true, although we don't have the longer-term reported outcome from the other randomized trial that started a little bit later. Do you find that data encouraging? Is it encouraging for your patients?
Yeah, I think that's very helpful, because that's what patients ask. They're unsure whether it takes away of the efficacy of the chemotherapy for the head, and so you can sort of comfort them and say, well, there is no data. We've always been saying that, but it was very helpful that you published these data here.
Yeah. It's a very rare event, but so it's a little bit hard to detect, but there is a good bit of older data as well as newer data, so it really helps to have all that together. But I agree, there's really no evidence at this point that that's an issue, but we should keep careful records and continue to do so.
Yeah, I think there's longer retrospective data from Europe showing that what patients don't always understand up front is that we actually do see scalp metastases as part of breast cancer at some small percent, but the key thing is there hasn't been any observed increase with scalp cooling, and so that's a message. It's in the FDA guidance, and so we counsel patients about that theoretical risk, but I very much emphasize that it's a theoretical risk and hasn't been appreciated in any of the studies that I've looked at, and your poster from this session will certainly help support that.
Intressant att höra marknaden och det praktiska kring den här marknaden. Framförallt höra den diskuteras av en tredje part. Mest anmärkningsvärd tycker jag är att så många aktivt väljer att avstå cancerbehandling på grund av risken att tappa håret. Ja, jag hoppas det bidrog till att ni har fått kött på benen vad gäller marknaden för skalpkylning och hur den används på sjukhus idag. Tack så mycket för att ni har kollat.